and talk about common fetal defects. Within this talk, I'll also be outlining what we mean by a fetal anomaly protocol. To say, if we say you have done a fetal anomaly, what is it that you have followed in your assessment for it to be adequately done? I put this tab. This tab has been in our books. Those who have done embryology, you agree with me that you have seen this kind of a tab, and it has always confused you. What do they mean? What is this tab? But this graph, or this picture you see on the left side here, what it is representing a case of fetal development, to say where are the systems vulnerable, to say where are the systems vulnerable. In other words, you are saying, when are we likely to be hurt? Let's take for example, if let's take for example, if the baby is exposed to some teratogenic substances, what period is the system more likely to be vulnerable? Understanding this kind of information helps you to counsel the woman, because the woman is going to come to you very worried that, doc, I have epilepsy, I've been taking lamotrigine, I've been taking sodium thiopental, I've been taking a lot of other drugs, or they will tell you other conditions where they are taking drugs which are likely to be teratogenic. So you need to have a general idea of what is vulnerable at what gestation. When it comes to the brain is always vulnerable all the way up to 16 weeks. That means if there is an insult, we are more likely to have a fetal defect at the level of the brain if there is an insult. Then from 20 weeks onwards, what we are going to have are more functional and minor abnormalities due to neuronal migration disorders. This is very important. This is very important because neuronal migration disorders are super difficult to diagnose in second trimester. These are third trimester pathologies. So that means the target time for coming for scan, it has to be changed. You cannot tell a woman who comes and tells you that at 21 weeks, I took something noxious to my brain. You send them for an anomaly scan at 23 weeks, which is perfectly normal, and you reassure that woman that everything is okay. When we know that neuronal migration disorders are disorders that we are likely to pick late in the third trimester. So this is where the understanding of this knowledge comes in, to say, when are you going to ask the woman to go for a targeted scan if you know the pathology, if you know the development of the fetus? Then the heart is pretty vulnerable around between the third to around the fifth week and a half. Is very vulnerable, the heart. If there is an insult at the level of the heart, it will lead to fetal malformation. But if there's an insult later on, sometimes we may have these mild stenosis. There's a mild form of heart abnormalities may be seen, the arrhythmias and so forth may be manifested if there's an insult after the formation of the heart. The upper limbs, more or less the same, and the lower limbs. And you can see that these other organs, after 9 weeks, they are not very vulnerable to most of the noxious substances that women may take. So that if a woman tells you, look, I took something at 16 weeks, for sure, you should know that the heart is highly unlikely to be affected. So there are the upper limbs and the lower limbs, and you should know what your target organs are when you are scanning the baby. The same way with the ears, the eyes, you can see that around 20 weeks moving forward, they are likely to be vulnerable. Once they are formed, they are formed. But as for the eyes, they behave just like the brain, that the vulnerability continues throughout pregnancy, that you may have blindness if the baby is exposed to teratogenic substance at any time during the pregnancy, while we may have malformations, severe malformations like microthomia, hypo or hypertelorism, if the insult is very early, before 8 weeks. So that's the usefulness of this kind of message whenever you are giving this message to women. Then in terms of the palate more or less the same, around 9 weeks, everything should be fine. The teeth, they continue. This is the reason why teeth discoloration tablets like doxycycline or tetracyclines are greatly discouraged in pregnancy. You can see that the teeth will always remain vulnerable throughout the pregnancy. So there is no safe place to take for any bone modifying or bone coloration drugs, coloring drugs in pregnancy. Then external genitalia, something could still go wrong later on in pregnancy if a woman takes harmful substances in pregnancy. So, as you can see that this coloring represents major defects and the other one functional and minor abnormalities. Then in terms of the 1 to 2 weeks, this is why you have to be precise. Whenever a woman tells you that I took something which I think is harmful to my baby, make an effort to try and be precise at the precise gestation age, which the woman could have taken the harmful substance, so that you could work around and give the woman the correct advice. If they tell you, look, I took it before I was pregnant, you know that they are likely to be okay. So that when you mix your ultrasound scan findings with the woman's history, you can reassure the woman in the correct way. Then what are the commonest defects that you are going to meet? From the CNS, you are going to have spina bifida or myelomeningocele, hydrocephalus, or ventricular megalith. We mainly see ventricular megalith rather than hydrocephalus. I'll explain the difference later. Then we have holoprosencephaly. Then on the heart, we have AVSD, BSDs, coarctation of the aorta, very difficult to diagnose in uterus, transposition of great vessels, and also tetralogy of Fallot. Then in the extremities, short extremities, that's what we mean by amelia there, adactyl meromelia, which is either absent of one of the extremities, part of the extremities. Then with eyes, we may see macrothalmia, hypotelorism, hypertelorism, cataracts, and glaucoma are super difficult to diagnose. Face, cleft lip and palate, flat face, hypoplastic nasal bone. We see all these abnormalities as you see from some of our work. Then kidney, you may have renal genesis, multicystic kidney disease, or you may have lower urinary tract obstruction, which is fairly common. Then at the level of the placenta, any insult to the placenta from one drug or another, or from infection, may result in placenta insufficiency, leading to fetal growth restriction. Then if you look, one of the reasons that worries us is probably this table here, this pie chart. If you do look at the pie chart, you see that globally, about 10% of the cause of perinatal mortality are due to fetal defects. And if you compare it with our own data, fetal defects are not featuring anywhere in the top 10. It's not because they do not exist, but it's because they are being grossly underdiagnosed, because there is no standardized protocol in which women are being scanned. And it is only recently that our government, our Ministry of Health, is putting measures for a woman to get at least one scan during their pregnancy. So the purpose of this talk is to encourage women to change this, to encourage all of us to change this pie chart, because this pie chart is totally wrong. If you are missing the cause of why babies are dying, you are either punishing yourself so much, thinking you are so good, when you are trying to save babies who cannot be saved. Probably in one of these pie charts, in one of these sections of the pie chart, there are lethal defects there which are hidden as other things. And you are extremely punishing yourself, saying you are making them die so much. Yes, there is nothing you could do. One of the reasons why the European and the American pie chart will never match with us in the next 5 to 10 years is because they are babies who have major defects and lethal defects. They will never contribute to this kind of data. Why? Because they are terminated either in the early, let's say, first trimester or second trimester. Yet ours are allowed to go all the way to term. So this is the reason why our data will always confuse us, because we have a lot of hidden mortality which we cannot explain. Then from our cohorts, this is not updated data. We now have more patients than this. From our cohorts, where we scanned patients, the incidence of fetal defects was about 3%. And this is the order of occurrence that the central nervous system at 27%, and this CVS at 20%, and the skeleton GRT at 10% of 8% each, then the rest is what you see. So what is the message? The message is that fetal defects indeed do occur. And this is the order or the frequency of occurrence when it comes to cardiac defects. You can see that AVSDs are fairly common, the commonest. Tetralogy of Fallot was fairly common in this cohort. We will see what the updated cohort is, and also arrhythmias. Then the CNS with ventricular megalith, myelomeningocele, aloba, let's just say holoprosencephaly there was also in the top. Then hydronephrosis, renal agenesis, and PUF, posterior urethral valves, and the multi kidneys and others form the rest. Then we have the first defects. We have cleft lip and palate, we have proboscis, arynia, hypotelorism. All these defects are what we are picking locally. So defects do indeed exist. Well, there is this misconception that thinks that fetal defects is a thing of the West and doesn't exist in the Zimbabwean women. This may be the reason why some women are not even sent for an anomaly scan. Then we have gastroschisis as the commonest in that category. Then we have fetal ascites or valocele, and on the skeletal defects we have short extremities, which is malleus. Then we have kyphoscoliosis, clubfoot, and chondroplasias. In terms of the fetal anomaly scan, what is the actual technique? How should it be done? The actual technique is that the baby should be examined from head to toe, and the optimal period is 20 to 22 weeks. Of course, you may see it written 18 to 22 weeks in your book, but we recommend 20 to 22 weeks to increase the completion rate. And who should have it? All pregnant women should have it, because even women with a low risk pregnancy will have a fetal defect. There is no precise method for identifying women with increased chance of fetal defect, because the majority of fetal defects occur to women without any risk factor whatsoever. So all women should be offered an anomaly scan. And these are the abnormalities that you should be looking for. I'll emphasize them as I do the presentation. All right, let's go through the protocol to say when you are going through the head and the brain, what is it you should identify for you to be happy and say this baby's head resembles a normal head? So if you look at one of our images there, this is the anterior complex. These are the anterior horns you see, and the box you see here, the cavum septum pellucidum, and this is the midline. The midline, that's the forks here. So we see the thalami, one thalami, then the slit of the third ventricle is somewhere in between, and we see the continuation of the endohemispheric membrane or fissure there. So it continues to the back. So the line should be straight and interrupted by the box of the cavum septum pellucidum, and you have the thalami and also the posterior horn of the lateral ventricle and the choral plexus in. So this is what you would consider when you measure the antrum or the width of the posterior ventricle, posterior horn of the lateral ventricle. It should not be more than 10 millimeters. So if we check here, you should make sure the shape is normal. So the shape should more of it be an ovoid shape. It should not be, it should not show scalloping or bones, what you call a lemon sign, while referring to the European lemon, not our lemon here. Our lemon here is rounded. So the European lemon, which is tapered at the front, that's a lemon head. And it should not be like a clover leaf, neither should be like a strawberry. A strawberry means more rounded, like a strawberry. So it should not be like that. Then the line I've already emphasized that you should see that line continuing after the cavum septum pellucidum box. Then you should see those anterior horns, and you should see the cavum septum box. Then you should see the thalami, then the slit of the third ventricle, which in most cases should not be visualized. If it is visualized, and you should measure to make sure it's not dilated. Then of course the line should continue at the back, and you should have the posterior horn very clearly visible, and you should see the choral plexus. And when you measure, it should be less than 10 millimeters. So if you do this kind of assessment on the baby's head, You have ruled out a number of abnormalities that we will discuss as the lecture continues. Then when you look at the posterior fossa, when you go down at the baby's brain and you look at the posterior fossa, you are going to see these structures. This is the cerebellum, the structure you see there. Within this cerebellum, two cerebellar lobes, there is the vermis, which should always be there. You will see in some of the images where we do not have a vermis and the cerebellum shape looks funny. Then we have the cisterna magna, and it should be measured. There are nomograms. Of course, there is no, it's always difficult if the vermis is there to say what do you do with the small cerebella. Nobody knows what to do with the small cerebella if you see the vermis. But if you have verminogenesis, then that is certain connotations. This cisterna magna space should always be visible. It should not be more than 10. If it is more than 10, then that's a megacysteny. And on top of that, it should not be obliterated. If it is obliterated, then you need to go and check and make sure that you are not dealing with anode carry or a huge myelomeningocele tethering and pulling down the posterior fossa structures to the back. So it should always be visible and within normal size, the posterior fossa. So I've outlined the cerebella there to help, and also the cisterna magna space is well outlined. Look at this image as you scan to go down there. You can see we go down to show the cerebellum. This is the fourth ventricle. The first ventricle should never communicate with the cisterna magna. If it communicates with the cisterna magna, then there's a problem. So that's the fourth ventricle, that small high anechoic area you see there, and this is the cisterna magna space. So there should not be a continuation between the two. That's a normal brain anatomy. So that's the labeling there, as you can see. Then when you go down to your usual position where you do the stomach, the abdomen, we expect you to see the stomach. The stomach should always be visible as one bulb. So that's the stomach here, and this is the umbilical vein. The umbilical vein should always be turning to the right, so you can see the stomach, the umbilical vein. The short part of the umbilical vein is what you would want to see when you are doing abdominal circumference. But for the sake of the anatomy, you should make sure you have seen that the stomach is present. There are other structures we can check here. What I've marked here is the aorta. Now we are looking at the situs to just make sure that the situs is correct. The aorta should be closer to the stomach and slightly on the left, and the inferior vena cava should be on the right. That's a normal arrangement of blood vessels within the baby's tummy. This is the aorta, the inferior vena cava. So if you draw a line across the midline, you'll see that the two are on the opposite sides. So your line should go through the umbilical vein, because this umbilical vein is what is coming out at the belly button position, at the umbilicus. If you are good, you are also going to identify that there's a spleen at the back here, at the back of the stomach. That's the spleen we see at the back of the stomach. And one rib continuous should be visualized to make sure you're not too oblique. Because if you are oblique, you may cut the stomach in two planes and think that there's a double bubble sign. So you should make sure that you are strictly transverse as you make the sweep at the level of the abdomen. So this is how the abdomen should be examined. Then when we turn our probe and put the spine at 12 o'clock, we will be able to see the renal pelvis. So these are the two kidneys and the renal pelvis measured there. If this is a second trimester, we'll be saying there's just minimal dilatation of the renal pelvis. We use a cutoff of 10 millimeters to diagnose mild hydronephrosis. So within this, we may say it's normal, but we may put this baby under surveillance to make sure it doesn't get worse and get to the level of hydronephrosis. So we measure from inner wall to inner wall of the renal pelvis of the two kidneys, as shown there. Then at the level of the abdomen, we have to check the condensation and make sure that the condensation is coming out on a well-formed anterior abdominal wall. And we are seeing these three lines as highlighted there by these colors there, that there is indeed three lines of the umbilical vessel coming. What anomalies are we trying to screen for? We're trying to screen for gastroschisis, exomphalos, and sometimes bladder extrophy, because in bladder extrophy, the condensation will be very low and close to the bladder. Right. Then as for the extremities, the femur always has to be measured it is actually a window in screen for skeletal to measure. Then we go for the upper extremity where we do all the check, make sure that there is indeed an upper humerus, and also there is a radius and ulna. They should always be checked, and the fingers, we count them during the anomaly scan to make sure there are 5 fingers in the hand. The same way with the lower extremities, we need to make sure we've seen the thighs, we've seen the tibia and fibula, and we have assessed the angle of the feet, including doing a footprint, of the baby to make sure we rule out both sandal gap. We also rule out the extra toes and also club foot. Then when it comes to the heart, not as part of doing a fetal cardiography, but as part of assessing for fetal anomaly. So the 4-chamber view, even anyone who does a fetal anomaly should be confident in doing a 4-chamber view assessment. How do we assess a 4-chamber view? First of all, we should make sure that the heart position is the apex to the left, and with the left ventricle forming the apex. So this is the left ventricle, and we should make sure it is indeed forming the apex being formed by the left ventricle. Then the heart axis, when you draw a line from the spine to the sternum and make an angle through the interventricular septum, we should make sure this angle is less than 70 and more than 30. So that is normal axis angle of the heart. Then the heart size should be measured if it is suspected to be big by doing a circumferential measurement of the heart, and we do the same at the level of the thorax, but using the ribs as your landmark, not the skin, for the thorax circumference. Then the ratio should not exceed more than 60%. If there is more than 60%, then you are talking of borderline ventricular megalith. If it is even worse, then indeed there will be cardiomegaly. The atria should be of equal size when you look at them. Then the ventricle should be of equal size, and the morphologically left ventricle should be the left ventricle. The morphologically right ventricle should be on the right side. What do we mean by morphologically right? The right ventricle has a moderate bend towards its apex. This is what we are looking at here. So this is the moderate bend. This should always be there, and this should be on the right side of the heart. Then we should see that the AV valves, the crucix is forming an X, is not forming a T sign. It should not form a T sign. If it forms a T sign, then we need to suspect an AVSD. And the septal leaflet of the tricuspid valve should be inserted at a lower level compared to that of the mitral valve here. Right. So, and the pulmonary veins should be seen to be draining into the left atrium. These are the pulmonary veins there, the ones we see. Then the interventricular septum should be seen to be continuous without any gaps or interruption. Of course, there is a better way of checking this. And the AV valves should be patent and fully opening, and without showing evidence of abnormal thickening at the AV valves. I think I've exhausted what we have to assess on the, sorry, there is one more thing. Then the aorta should be seen to be close to the left atrium. This is the ascending aorta. The rounded structure there is the ascending aorta, should be seen to be close to the left atrium. So that's the assessment. So that's your right ventricle there, the left ventricle, the right atrium, the left atrium, and the aorta. And we have the lungs, and the lungs should be seen to be symmetrical and in position. You should not see a collapsed lungs. You should not see fluid around the heart. Neither should you see hydrothorax or pleural effusion. So that's the left lungs and the right lung. Then an attempt should be made to look at the three-vessel tracheal view, three-vessel view. How do you get the three-vessel view? If you continue moving your probe upwards while you're examining the heart, first of all, you arrive at these vessels where you are seeing the pulmonary, that's the pulmonary artery there with the valve, and you will be sectioning the aorta transversely, and the small vessel there is the superior vena cava. So this vessel should be seen to be arranged anteriorly from anterior to the posterior with the pulmonary artery, aorta, and superior vena cava in that order. And in terms of size, the aorta should subjectively look bigger than the aorta, and the aorta should subjectively look bigger than the superior vena cava. If there is an issue of the size, then a fetal echocardiograph should be done and precise measurements should be done, including assessment of the valves. So this is what I would consider to be optimal. For now, if we are doing a standard anomaly scan, there are left and right outflow tract, which I did not emphasize for this lecture for routine assessment, because I think they will make it very difficult to do a fetal heart assessment for now. But with the future, as more and more skills become, people improve their skills, then we need to go to that level without doing a fetal echocardiography. Then in terms of fetal anatomy survey, the profile should be seen the way you see it here. The nasal bone should be identified and measured, should be present. And the forehead, there should be slight frontal bossing of the forehead, slight protrusion, not bossing, slight protrusion of the forehead should be seen when you are looking, and the chin should appear to be in the same line as the forehead. The chin should not be receding backwards, because that may mean macronathia or may mean retronathism. And the nose should appear to be there, the tip of the nose there, and the resemblance of the lips when you look at the profile. Then the orbits should be seen with clear lenses. The round structures there are the eye lenses. They should be very clear. And the interorbital distance should be such that you should be able to fit an orbit in between them. If you cannot fit an orbit and it's too small, that's hypotelorism. If you think it's more than one orbit, then that could be hypertelorism. If the eyes appear smaller, too small, then probably you are dealing with a case of macronathia. If you have one eye just in the center, then in that case you are dealing with cyclopia, which is what you see in some of our cases we have seen already. Then you also have to check the lips. The lips are checked when you have a facial view and try to look at the baby's face, and you see that there is the upper lip, and we have the nostrils there, and the part of the filtrum and the nasal bridge seen, and the upper lip should be seen to be continuous. This is the lower lip. We rarely have lower lip cleft, but it is the upper lip, which is the center of the focus, and also the palate. You can see the top palate there. That's the palate, the roof of the mouth, and we are looking for gaps within this palate as part of screening for cleft palate. The spine should be examined with the baby by putting the baby's back to the front, as shown here, and the tip of the spine should always be visible or be identified, and we should try to be as mid-sagittal as possible. This is not a very nice mid-sagittal plane, because you should be seeing the spinal cord there, and the skin should be seen throughout all the way, and the checking should be applied. This just demonstrates that there should be continuous skin on top, and there should not be gaps there. And the checking should continue all the way to the neck, including seeing the cisterna magna from this position here. This space should always be there with fluid. If it is not there, that means there is tethering of the spine, and the posterior fossa structures are pulled down and obliterating the cisterna magna. So if you don't see it, begin to investigate the spine carefully. But the spine should be examined from its attachment all the way to the tip. Please don't just look at the middle. We have seen cases who are referred to us for ventricular megalith only, but when we look at the spine and tilt the back the way we do here, we discover that there's actually a sacrococcygea myelomeningocele at the tip here. So the spine should be seen right up to its end. This is a video. There should be a video here. Probably it's not coming. Oh la la. I don't think the video play, but that should be a video there. Okay, I'll move on. Then I'll go on to the defects to say what are the commonest defects that you are likely to encounter. When you're at the plane where you do the BPD head circumference, you are going to encounter a situation where you may see that the posterior horn of the lateral ventricle is dilated, as shown there. This condition is called ventricular megalith. If we establish through ultrasound scan that there is an obstructive pattern, then it will become hydrocephalus. Like in this case, where we suspect that there was an obstructive pattern, then this becomes hydrocephalus. Not all abnormal enlargement of the ventricular megalith are hydrocephalus. Hydrocephalus is only given if you highly suspect that there is an obstructive pattern to the abnormal dilatation of the ventricles. This condition is very common. It's 1 in 200 at the 18 to 23 weeks. If we are looking at mild form of ventricular megalith, and at birth is about 2 in 1,000. The reason why it is this low at birth is because some of the mild ventricular megalith cases self-resolve, and because this is data from the West, some of the cases will end up being picked with severe defects and they are terminated. So if you use the neonatal, prenatal, perinatal data, you may think that these conditions are not common, but if you use the prenatal data, then this condition is very common, as common as 1 in 100. Whenever we see ventricular megalith, we always tell the women that the causes could be chromosomal, or it could be genetic abnormalities, or it could be due to intrauterine hemorrhage or congenital infection with torch infection topping the list. So we always try to investigate along those lines. Ventricular megalith is classified, it used to be classified between mild, moderate, and severe, but that division has since been dealt with. It's either mild or severe. Mild, that is between 10 to 15, and greater than 15, that's severe ventricular megalith. It is very important because this speaks to the counseling message in terms of perinatal outcome. The association with chromosome abnormalities is between 1.5 to 12% if isolated, and 9 to 36% if it is associated with other defects. So in terms of obstetric management, we offer these women karyotype, and we also screen for torch infection. There is no fetal therapy once you have picked it up. What you read in the literature, like drainage of the ventricles, doesn't work. It's just experimental. Drainage of the ventricles in terms of therapy for this condition. Currently, there is no intrauterine shunt insertion which is widely recognized. Neither is there some laser opening of some obstruction either at the foramen of Monro or foramen of Luschner happening. So the prognosis depends with the severity and also the associated lesions or syndromes. If it is isolated and is mild, the prognosis is good in most cases because the majority self-resolve, and we have ruled out that there is an underlying chromosome abnormality. So the outcome is good, and our counseling is also more reassuring and encouraging for the woman to carry the pregnancy. But if it is severe, like in this case, then we know that in this situation, the perinatal neonatal handicap is around 50%, that they be severe mental and neurological handicap for these babies. So we counsel the woman that this is a condition that will lead to a severe handicap of a baby and will invariably need an operation called a shunt process, where the baby has to be operated on, and which will be followed with a number of complications lifelong. So in this case, termination of pregnancy is also offered as an option for women with this kind of abnormality, where it is severe and with clear destruction of brain parenchyma. Holoprosencephaly, this is one of the anomalies that really touches my heart. Holoprosencephaly, I do not know why it is missed, but most cases that do come to us, if somebody says it's holoprosencephaly, it's because they've passed through fetal medicine unit and they've told them about it. But in the majority of cases, they are being referred to us as ventricular megalith. And the couple who have been cancelled that they have a ventricular megalith, which is a totally different condition from what I'm going to talk about. Holoprosencephaly is a condition whereby the brain, during the 3rd to the 5th week, the brain fails to divide. The brain is normally supposed to undergo cleavage, both coronal, transverse, and also sagittal. But in this condition, there is abnormal division of the brain, and the brain fails to divide, so that instead of having a normal ventricular system, they will have a monoventricle. The failure to divide may vary to some degrees, so that we may end up with 3 kind of variants, 3 to 4 variants. The lobar form, there is no division at all, as you may see there. I will show you some pictures with semi-lobar, and then we have the lobar variant, which may confuse many, which is extremely difficult to diagnose. And we have some middle variants, which we may encounter, which again may be difficult to diagnose because they look like normal. These other 2 which I mentioned, their prognosis is variable, so missing them may not be that disastrous. But missing a lobar where there is a monoventricle and fusion of the thalami is not a good thing, because this condition is lethal. You are not going to meet anyone with a lobar holoprosencephaly walking in any part of the world. We have another one called semi-lobar, where there's partial segmentation of the cerebral of the ventricles in the cerebral hemisphere posteriorly with incomplete thalami infusion. You will still have a monoventricle in this variant. I will show you some of the pictures. The prognosis is just as bad as a lobar holoprosencephaly. It's also lethal. Then the lobar variant, there's normal separation of ventricles and thalami, but absent septum pellucidum. The prevalence is as common as 1 in 10,000. This is probably fair in terms of the representation, because we see them quite often. You will see our updated database on this condition, that we are diagnosing this condition very often here in our country. So it is indeed fairly common in fetal medicine terms. In fetal medicine terms, 1 in 10,000, we'll be saying it's fairly common. In Zimbabwe, we have 40 cases of this, but I think we're having more than that there. Etiology, it is heterogeneous, but it is associated with trisomy 13, which is Patau syndrome, in about 50% of the cases. Sometimes it could occur as part of a monogenic or a teratogenic etiology. So in about 30%, there may be an association with mid-fascial defects. And what are the mid-fascial defects? The mid-fascial defects we expect are hypotelorism. Look at this one of our babies. You can see how close the eyes are. I showed you on the protocol there that the eyes should allow another eye to be fit in between. But look at how close these 2 orbits are, which shows that it's too close. So this is called hypotelorism. Then we may have cyclopia. There are cases where the eyes fuse and you only have 1 eye there instead of 2. This is the same baby you see there. You can see there's only 1 eye opening, but you can see that there are 2 eyelids, they fuse together. But in certain cases, you only have 1 eyelid there. That's cyclopia. Then we may have a facial cleft, a cleft lip, and a cleft palate. Then we may have nasal hypoplasia. In this case, you can see there's total arynia. Arynia means there's absent nose. This was the case here. In certain cases, you may be just a very tiny nose. Then we have a proboscis. A proboscis is a worn soft tissue-like structure here. It appears like a worn, but it's all soft tissue. Some babies will be breathing through this because this proboscis may sometimes be below the eyes. So what is happening in this case is that the face fails to divide in the normal way, so the midline structures are fused and we have absence of certain other structures. So whenever we are faced with the holoprosencephaly, just remember that in 1 in 3 cases, you may have mid-fascial defects and you need to make an effort to check the face. Why is it important? This is important in counseling the woman, so that the woman knows that she's going to deliver a baby that looks like a monster, and she may choose not to look, because this may be super traumatic to certain women. Being in Africa, this can mean a lot of connotation that may be attached to this pregnancy, including bewitchment by aunts and by, by the unfavorables of the tribe. So women have to be warned that your baby is not going to have a favorable look, and you may decide not to take a look, because if the woman looks at this kind of a baby, to be honest, they'll think it's a tokology, is something that is to do with bewitchment. But these defects do okay in every part of the world. Then in terms of prognosis, I've already told you, Aloba, in terms of obstetric management, we do offer karyotype. The reason why we offer karyotype is due to recurrent risk counseling. If trisomy 13 is associated, the recurrent risk is about 1%. If there is no associated trisomy 13, the recurrent risk is about 10%. If there is an associated genetic syndrome, then the recurrent risk is about 25%. So this is the reason why we continue to offer fetal karyotype, so that we may counsel the women concerning the recurrent risk. There is no fetal therapy, no treatment, so there is no hope for these women. Please don't reassure them falsely. We have patients who come to us who are scanned from outside, and they come to our unit, and the person who have scanned them will have told them that please come back in 3rd trimester and we'll reassess the findings. There is nothing to reassess here. This is a lethal defect, and these women should be referred to a fetal medicine unit for proper counseling. You don't keep them with you and say, come back and I'll scan you again to reassess the findings. Then prognosis, a lobe and semi-lobe are lethal. Then the lobar type may be associated with mental retardation and endocrine disorders such as diabetes, insipidus, growth hormone deficiency, and I've already highlighted the recurrent risk based on the etiology. Then posterior fossa abnormalities. I've shown you what cisterna magna is and the cerebellum looks like. Sometimes when you are examining the baby, you may see that the posterior fossa has got this huge cyst like we see here. This was an arachnoid cyst in one of our babies. Or you may see that the 4th ventricle communicates with the cisterna magna and in a black pouch cyst condition. Or you may see that there is no cerebral cerebellar vermis in between the 2 cerebellar hemispheres here, lobes, and this is vermian agenesis. Vermian agenesis could be partial or complete, but this is vermian agenesis we have here, cerebral vermian agenesis. So these are some of the abnormalities with variable outcomes, with associated neurological, variable neurological outcomes. Acromia, exencephaly or anencephaly. This is one spectrum of a condition. If you do scan a patient at 11 weeks or 12 weeks, you are going to see that the brain is there, but the skull is missing. If you do scan these babies at 21 weeks or 32 weeks, because of exposure to amniotic fluid, the brain will undergo autolysis and there is no brain, and it becomes anencephaly. So it's one spectrum of a condition due to the failure of the formation of the cranial vault. The brain is exposed. So in 1st trimester, you will say it is acromia because the brain is there, but later on in pregnancy it becomes anencephaly. So why does it happen? Multifactorial, but others think it's due to folate deficiency and homocysteine metabolism errors. This is the reason why folic acid works in terms of preventing the recurrence of this condition. How common are they? 5 in 1,000. When can they be diagnosed? as early as the first trimester, they can be diagnosed as long as scanning is done according to protocol. However, it is easier to diagnose them in second trimester because you are going to fail to find the midline to do your BPDH circumference. So it is very easy in second trimester, and you are going to see this frog's first sign, and you will miss the brain. You are not going to see the brain in second trimester. In first trimester, you will see a disorganized brain without a proper first trimester midline and the choroid plexus in their places, in their respective place. Chromosome abnormalities may do okay in about 2 to 3% of isolated cases. So as a rule, we do not offer karyotyping because karyotyping is not going to change the future pregnancy management or the counseling message. This is a lethal defect. There's nothing to tell the woman to say, please come back and you reassess the findings. It's acromia, it's anencephaly. No one walks anywhere part of the world without a brain. This should be very clear because sometimes women are given mixed messages. They are scanned and somebody says, please come back, I want to reassess you again in 4 weeks. To do what in a baby without a brain? You refer to a fetal medicine unit for birth counseling and for assistance in termination of pregnancy if need be, because legal papers have to be done for this. Then in terms of prognosis, we've already told you it's illegal, it's incompatible with life. Please, this is the message. Acromia and anencephaly, it's a lethal defect. There is nothing to reassure the women here. I'm emphasizing this because this is what we are experiencing. We are meeting women who are reassured when they are carrying an anencephaly baby. So there is nothing to reassure the woman and tell her probably things will change. Can you come back in 4 weeks so that we see if things have changed? Right, open spina bifida or myelomeningocele. When you are doing the spine measurement and you are looking at the spine, you will see a break in the continuity of the scan as shown by one of our images here. So you can see that the spine is not forming a nice railway line as you saw on the previous protocol images. So that's a cystic structure, which is a myelomeningocele on one of the babies shown here. This baby is more of a thoracic myelomeningocele. So remember, the myelomeningocele may exist from the cervical to the thoracic to the lumbar to the sacral to the coccygeal area. This is why I said the spine has to be checked throughout. You don't just check a middle part of the skull of the spine and you walk away and say, I've done it. You will miss myelomeningocele. There are other fairly common, 1 in 1,000, mostly in a population that doesn't take folic acid at the right time as ours. So it is fairly common. Then in terms of the indirect signs, the lemon sign, the banana sign, and the obliteration of the cisterna magna are some of the indirect signs. A late sign such as the ventricular megalith may be picked. So every baby who has ventricular megalith should be investigated for a myelomeningocele as a rule of thumb. So remember that because babies are referred to us with a diagnosis of ventricular megalith, but without the mention of a myelomeningocele, because the person is coming, just checked the brain and they didn't bother to examine the scan properly. Yet there is a myelomeningocele. The counseling is different. In most cases, they have mild ventricular megalith. But if somebody is a mild ventricular megalith and they have a lumbosacral or a thoracolumbar myelomeningocele, that changes the message and that changes the outcome of the pregnancy. So it is important that all detail is obtained because what we tell the mother in the packaging of the information for the management of the pregnancy should be based on a full assessment of the baby. So when you look at the vertebra, you see that there may be C or U-shaped on the affected part or interruption of the continuity of the skin or splaying of the lateral processes. Then the other associations are talipes, bladder distension, and hydronephrosis. So that means all these systems should be checked whenever you come across a myelomeningocele condition. Then chromosome abnormalities do exist in 8 to 16%. So we do offer these women karyotyping, and the therapy which is now there, which is being offered in some centers for carefully selected babies, there is now MOMS or myelomeningocele, intrauterine repair of the myelomeningocele through fetoscopic repair. It is now happening. There is also open surgery where a hysterostomy is done and the fetal spine is extracted and the fetal bag is taken out of the uterus and the defect is repaired and put back. Some of the results which are coming out of these studies are reassuring. Probably in the future, this will become standard therapy everywhere, that we could attempt intrauterine repair of the myelomeningocele in selected patients. Otherwise, what we try to establish when we see these cases is to assess the level of affection, to say where is the level of affection. If it is in the sacral and coccygeal area, there is a better hope there than if it is in the lumbar and sacral area, and there is no hope if it is in the thoracic and lumbar area, because it means some diaphragmatic muscles are also involved, nerves are also involved if it is in the thoracic. If it is in the cervical area, then it cannot be incompatible with life. So for those cases, we offer termination. We try to do a gross assessment of the neurological function. So we assess the movement of the limbs when the baby is in uterus. If the baby appears to be able to move its ankle, to move the knee joint, then we can reassure the woman that probably we may achieve bladder control. We are not sure about the sensation, but bladder control and some motor function may be achieved, of course, after the defect repair and absence of complications such as infection and so forth. So we try to get this kind of detail when you are scanning them for the counseling processes, so that the couple can make a decision to either continue with the pregnancy, knowing the need for surgery or the possible outcome scenarios, or they choose termination. This is an example of a more sacrococcygeal. This was a hidden one. This patient was referred to us because the guys who scanned it thought she just had the ventricular megalith. When we looked carefully, we noted that it was just pooping out here, right at the more coccygeal area. If you are to count these bones, that probably around S1 there, it is popping up, maybe L5, S1 is popping out. Normally, these are very good outcomes, the ones that pop out right at the tip there. So this is a good outcome. Of course, the defect has to be repaired, but motor function can be established here, and the bladder control and sphincter control will be good, but sensation may be slightly impaired for this kind of babies. So it is important to be able to identify even these terminal ones for counseling purposes. They're hard. So when you are doing a 4-chamber view, sometimes you may see this kind of pictures, like I told you that you should see a crux. So if you don't see a cross, crux in French and cross in English, so you should see a cross there where a crux, an X, sorry, not a cross, an X kind of, a French cross, which is an X kind of. When you are looking at the insertion of the valves there, here you can see that is missing. You can see that there is a one opening into the ventricles there, because this is an AVSD. So this is an abnormal 4-chamber view. Even when you eyeball it, you can see that it's totally different from the 4-chamber views that I showed you. So this is an AVSD, an abnormal 4-chamber view with an arterial ventricular septal defect. Then we are trying to look, probably to just mention a little bit counseling information. So AVSDs are associated with Down syndrome in about 50% of the cases. So we always tell the women that we need to do a fetal karyotype, because this will influence of course it doesn't influence the overall outcome, but the woman needs to know that Down syndrome may come with other complications, and also the issues of physical and mental handicap associated with Downs. But the outcome of AVSD is not affected by the existence of Downs. But the counseling message is that these babies will need operation at some point, because they will struggle to maintain proper oxygenation, and they will struggle with effort, because blood is mixing oxygenated and non-oxygenated blood there. So at some point, they will need some extensive operation to try and correct this abnormality. We don't routinely offer termination for these women, but we told them that there will be need for a fetal. It's a major defect which a couple may choose to terminate. It can be legal because there is a severe handicap here. Another condition, I remember at some point when I was in France, the obstetric colleagues posted this picture. It's not playing. I'm sorry. This is supposed to be a video. And I think there was a lot of argument. People didn't know what they were looking at then because people were saying, what is this image? Somebody posted in the group. But this is Ebsen's anomaly. Ebsen's anomaly is a condition whereby there is abnormal insertion of the tricuspid valve leaflet. Instead of the tricuspid valve leaflet inserting at the right level, it is inserted lower down, and the valves themselves become dysplastic. That means they don't open and close very well. As a result, they are going to be leaking blood or to have a lot of regurgitation. What you are seeing as the red thing there is a regurgitation jet. So due to the effects of this regurgitation jet, there is going to be abnormal dilatation of the right ventricle, and this will make the heart enlarge so much so that it's going to squash the lungs, and also going to lead to some high volume cardiac failure, which may result in fluid in both the in most of the compartments, like the abdomen, and also you may see some fluid in the chest. This condition is a major defect with a lot of handicap, so that it's as good as a lethal condition. Of course, babies do not immediately die from this condition, but they're going to struggle. They'll be put on anti-failure. They will need ventilation, and the heart will not recover, and the dysplastic valve is not going to self-repair. It will remain dysplastic. There will remain regurgitation. There may be need for even valve replacement for these babies to function. So this defect on its own, because of this severe morbidity associated with it, we also offer termination of pregnancy as an option. So I've taken through two common defects of the heart, but there are many defects of the heart which will be covered in the future under fetal echocardiography. Right. When you go to the abdomen, as you go down, doing your abdominal circumference as always, you're going to come across a situation where you see two bulbs next to each other, as shown on the video. One of our videos, they look at that. So you can see that there is some communication down there. So what are these two bubbles? One of them is the stomach, and the other one is the duodenal portion. What you are seeing as a connection is the pylorus part. The pylorus, which is now distended with fluid, because the duodenal is stenosed after its first part. So in the second part of the duodenum, there is some constriction there. So what is the stomach and the first part of the duodenum are distended, connected by the pylorus. By the pylorus there. This condition comes associated with polyhydramnios, where the baby is not able to swallow, is swallowing, but is not able to take the fluid, the small intestines and the large intestines where it is supposed to be absorbed. So fluid will tend to accumulate, and they will have polyhydramnios. How common is it? 1 in 5,000 births, but prenatally they are more common than that. As common as around 1 in 3,000 or less, but because some of them may be terminated or may have intrauterine fetal demise due to other associated defects, the postnatal figures are sort of underestimating the actual prenatal existing of the condition. So I've already told you about the double bubble sign. Then polyhydramnios may normally occurs after 24 weeks, but you may see it earlier than that. Then trisomy 21 exists in about a third of the cases. So whenever we see duodenal atresia, we push for karyotype. We want to know if there's an associated defect, chromosome abnormality. In this case, the existence of an abnormal karyotype influences the prognosis of this baby. Then there may be association with cardiac, renal, and vertebral which may be found, defects which may be found in about 10 to 20% of the cases. So a detailed evaluation of all these systems has to be done. When should they be delivered? Around 38 weeks. That's the optimal time for delivery if there is no evidence of fetal compromise. The survival rate in isolated cases is very good, about 95% of the cases. But these cases should deliver in a surgical center, not outside the surgical center. Why? Because if they are delivered outside the surgical center, there's a high chance that this baby is going to vomit. Somebody's going to make a mistake and feed them, and they'll vomit into their lungs, and they have pulmonary pneumonitis. And this is what they will die from. That delay in feeding may also make the prognosis worse. So once you have identified duodenal atresia, to the central hospital which operate babies, that is Mpilo and Salimugade, not anywhere else. Please don't deliver duodenal atresias, even at Parenyatwa. Never deliver them at UBH if there is no surgical unit that is dedicated to babies. But that delay, with the disorganized system we have, that delay in transferring this baby from Parenyatwa to Salimugade may change the prognosis of this baby. So once the duodenal atresia, the delivery place should now be changed to go to a center that operates. This is something that the referral system doesn't take into account of, but this is what we are appealing to people in the referral chain to understand, that there are certain babies which have to be delivered at the site of intervention to save them. Exomphalos. When you are trying to get the 3 vessel view that come out of the belly button, you may see that instead of that, there is now a mass, and at the top of the mass, you see those 3 lines. You see it here and there. In this case, there is a defect of the anterior abdominal wall. The anterior abdominal wall didn't form properly, so you now have the liver in there. Sometimes you have the liver, more of it. Sometimes you have the intestines, more of it, and of course the liver. But the abdominal contents are now extruded outside. The stomach may also be outside and the liver outside. This is the example for our baby. One of our babies is Sally, who came out like this. Fortunately, our pediatric surgeon team came and do an exit procedure. Before the umbilical cord was clamped, they were already closing it. They did an amazing job on the baby. So this is an exomphalos there from one of our babies. How common is it? 1 in 2013 weeks, association with trisomy 18 or 13, 30 to 50% of the cases. This is what makes exomphalos a poor prognostic condition compared to gastroschisis if picked in uterus. Our neonatal colleagues will present for you neonatal data, which will seem like the 2 conditions have the same outcome, but they are not taking into account the ones who that was trisomy 18 and 13, 80% of the babies with this condition have intrauterine fetal demise. So we are saying from the perspective of fetal medicine, when you counsel women and tell them that it is a poor prognosis, this is why we tell them that, because we know of the association of trisomy 18 and 13, about 30 to 50% of cases, which is discounted by the intrauterine fetal demise from the neonatal data for those who are born alive. So please take note of this, because you will see our neonatal colleagues presenting data where they show you that, look, they have the same outcome, they have the same outcome. It's because they did not take into account the intrauterine fetal demise from trisomy 18 and 13, which is very rare in gastroschisis. It's normally not associated with all this. Karyotyping and molecular testing should be done for these cases because of the high association. Then in terms of outcome, if isolated, survival is more than 90% for small and moderate. But if it is associated with other defects like cardiac malformations and trisomies, then the outcome is very poor for this condition, so that we cancel towards termination. Then delivery is at 38 weeks. For those babies who get to delivery and everything is okay, for sure we reassure them. So far, for the cases that we have managed within the fetal medicine unit and our surgical teams have managed to respond timeously, for sure the survival is this good. But for babies who are born outside, who are transferred from non-surgical centers, the outcome is shocking. It's less than 20%. The outcome, the survival of these babies from the data presented by one of the pediatric surgeons some time ago. So delivery place is very, very important. I can't overemphasize this. Please don't be brave. Don't deliver an anterior abdominal wall at your hospital if you don't have a surgical unit. This applies to Parenyatwa. This applies to UBH or any other hospital in the country. Don't deliver a gastroschisis or an exomphalos if you want to give that baby a chance. They should deliver at Salimugabe and they should deliver at Mupilo. That is it. Any other experiment is just a death sentence. Gastroschisis. So what is the difference? In exomphalos, there's a very nice membrane engulfing the intestinal content. This is why it is a pleasure for the surgeons, because the membrane covering is already there for them. So it makes it easier to push things back and also remove some of the complications associated with other defects which I'll mention now. So gastroschisis, there is no membrane. The intestines are just floating freely in the amniotic cavity, and the membrane is to the right of the umbilical, and the umbilical is coming out at the margin of the abdominal wall, not at the top, like what you see in exomphalos, for you to distinguish the two. Sometimes there may be what looks like a pseudomembrane. This is why I'm emphasizing this. When babies come out, they come out like that. So how common is it? 1 in 3,000 at 13 weeks. Of course, it's less at best because some may have other complications, fetal growth restriction, some may die from other causes. But the number of those who die is less than those for exomphalos because of trisomy 13 ATF. The risk of trisomy is not increased, so we do not offer them amniocentesis. These cases, we reassure them if it is isolated. But however, if it is associated, we have to offer them amniocentesis for karyotyping if there is an association. Then the trisomies, the ultrasound scans are done every 4 weeks to monitor growth because of the high association with fetal growth restriction. Then in isolated cases, the survival is very good. However, the counseling message we give these women is that in about 10 to 20% of cases, the babies may suffer from short bowel syndrome because some of the bowels will be stenosed and the surgeons have to remove it. So they may suffer from the effects of short bowel syndrome, which is poor handling of electrolytes for these babies in the long term. So they would fail to thrive in the long term if they have a short bowel syndrome. But generally, gastroschisis isolated, we say good news to the parents and we reassure them and give them optimistic hope because of the good outcome. To just run you down some defects, which I will not go down in detail. Fetal ascites should always be investigated. The majority of fetal ascites may self-resolve if there is no identifiable cause. We have had this experience where it self-resolves, but if there is identifiable cause, in most cases it won't self-resolve. There are many causes of fetal ascites which we are not going to, but whenever we see fetal ascites, it's a cause of concern and they should be referred to a fetal medicine unit. Sometimes you may see absent stomach, which will be associated with polyhydramnios. If the stomach is not seen, then the likely cause is, of course, you don't do it in one setting. You have to ask these women to go and take a walk, drink something nice, and come back before you are sure that there's no stomach. Sometimes the baby could have just emptied it. So if you double check twice after any interval and you don't see the stomach, for sure you can confidently say you didn't see it and refer to fetal medicine. And the likely diagnosis in this case is esophageal atresia if there is associated polyhydramnios. So esophageal atresia in an absent stomach situation. Sometimes you will see distended bowel. This is a condition which is common in the 3rd trimester. So this is one of the reasons why you may miss some defects in the 2nd trimester because defects like distended bowel, you will not pick them often in the 2nd trimester, but these are 3rd trimester diagnoses. The most common is called ileojejuno atresia, and we always say if they are prominent, We use a cutoff around 15 to 17 millimeters when we are measuring the width for us to say ileojejunar atresia, and we put these babies under surveillance for us to know whether there's a strong obstructive pattern or not. We look at the peristalsis. As you know from general surgery, if there is severe obstruction, there's going to be increased peristalsis, increased dilatation of the bowels. Ileojejunar atresia does not often come with ascites because it's lower down from where the water is absorbed. So they don't often come with not with ascites, but with polyhydramnios. So don't look for polyhydramnios in these cases. Sometimes we may have volvulus conditions. They may also exist in the fetus, and all these babies will need to be cancelled. In most cases, the prognosis will depend on the residual intestines at birth to say how much of it is still working, because if the obstruction is strict and there is continuous peristalsis, by the time the baby is born, most of this of the descended intestines have become redundant. That means there would be no neurological function. It will not be able to participate in the peristalsis movement at birth, and it has to be removed. So short bowel syndrome is another complication of this condition. Urinary tract abnormalities. So these vary from hydronephrosis. As you can see in one of our images, it's not in the perfect position. This one is. So you can see this is a dilated renal pelvis, more than 10 millimeters. Division mild to moderate, 10 to 15, severe, greater than 15 millimeters. Whenever we see it, you also want to check the bladder and to look for evidence of hydroureter to try and identify the site of the obstruction. However, mild hydronephrosis may not have any obstructive pattern, but may be a soft marker for aneuploidy, like Down syndrome. Then posterior ureteral valves. Posterior ureteral valves, we normally see a distended bladder with abnormal thickening of the walls and the keyhole side. I'm sure I'll have an image somewhere down there to show you. And in cases where we have total lower urinary tract obstruction, we may not even have fluid or may have severe oligohydramnios. These are echogenic kidneys. When kidneys become too prominent, we suspect them to be echogenic. Because assessment of renal function in utero is not very accurate, we normally put these babies under surveillance. We do not offer termination. We don't do any specific investigations if it is an isolated finding, but these babies have to be put under watch. A neonatal alert has to be put, and the renal function has to be assessed after birth. They may suffer from some degree of renal impairment, or some of the echogenicity may be due to renal dysplasia. Some other fetal abnormalities that you may come across: a flat face. I showed you a profile. Look at this one. This was a flat face in a baby who turned out to have trisomy 13. Trisomy 13, one of our babies. Look at how flat it is. Look at the nasal bone. Everything is flat here. Then cleft lip. I showed you an image of the upper lip and the nostril filtrum. Look at the disruption of the nasal bridge filtrum and the discontinuity of the upper lip there. That's a cleft lip there. Cleft palate. I showed you a nice continuous white line at the top of the below the lip there. Now you can see a disruption of that white line in two sections, almost two sections. So this was one of a baby with bilateral cleft. Then here with the short nasal bone, a hypoplastic nasal bone. You can see it's very short, the nasal bone in this case. Of course, it has to be measured to be certain and plotted on the nomogram. Skeletal dysplasias. The window is to measure the femur and the humerus. We do measure the femur and the humerus during anomaly scan. So if the femur is short, the length, the structure, the mineralization of all the bony structures have to be assessed if you are faced with a short femur. This is an example of a short curved femur. There are more than 100 skeletal dysplasia conditions. So we have to do what you call a pattern approach. The moment we pick an abnormality in one of the skeleton, we have to look for other features to try and classify the skeletal dysplasia either into leader or non-leader. The most defining factor in most of the cases, 1, mineralization, 2, the thorax head ratio, in terms of the size of the thorax, to say is the thorax developed or not, or is it remained narrow? And of course, the head appearance also has a bearing, any CNS abnormality. So we have to classify them along those lines in terms of the counseling process. Sometimes you may see some nuisance features. You may see choroid plexus cyst, where patients who are referred to us because they have a choroid plexus cyst. What happened to one of my images? Okay, a choroid plexus cyst within the ventricle here. Choroid plexus cysts, in most cases, they are normal variant. They disappear on their own around 26 weeks. But if they do persist, we might need to do torch. They are a weak association. They have a weak association with chromosome abnormalities. If it is the only marker you see after the woman has been screened for aneuploidy, the likelihood ratio for this marker is around 1. So it's not going to change the background risk on its own, choroid plexus cyst. So we don't do extensive investigation on a woman choroid plexus cyst. We always ask them to come back and see us after 26 weeks. In most cases, they will have self-resolved choroid plexus cyst. Please take note of this, because especially if we have students in here, but this is an examinable question. We see some weird management plans for choroid plexus cyst, but to be honest, it's a normal variant. Multicystic dysplastic kidneys. This is a normal kidney, but look at this kidney, look at this kidney, look at this kidney. We have women who are being referred to us with a diagnosis of polycystic kidney disease after people have discovered that they are these cysts. It is very important that we are able to distinguish between multicystic and the polycystic kidney. Multicystic kidney, they are going to be huge cysts. Whether they communicate or not communicate, then that will mean a differentiation between severe hydronephrosis or multicystic kidneys. These two conditions, a severe hydronephrosis and multicystic kidneys, they have the same outcome. If it is unilateral, it is just good as there is unilateral renal agenesis. Unilateral agenesis, let me say, is not a leader condition. You don't need 2 kidneys. You need 1 kidney. Probably God gave us 2 so that we have a spare 1 to give our relatives if something happens. But you function with 1 kidney in a supernormal way. Your renal function is not going to impair because of 1 kidney. The thing is, if you label the woman as having polycystic kidney, the women are going to go to the internet and read about polycystic kidneys. Polycystic kidneys is a very bad condition. It is bad in the fact that most of the kidneys will fail eventually, either in childhood or early adulthood, because there is severe compromise at the level of the glomerulus and so forth in the polycystic kidneys group. So polycystic kidneys is a worse kind of disease in that it has a long-term impact. So that when you label somebody as having more polycystic kidneys, you have sort of condemned that baby to a life of suffering. The baby will have chronic hypertension from renal problems, and they will eventually develop renal failure. Polycystic kidneys, this is a kidney which was obstructed during the 3rd to the 5th week of kidney formation. As a result, the collecting systems within the kidneys did not connect with the bladder. As a result, there is now the accumulation of urine within the collecting systems of the kidney. This is what you see represented with these swellings you see here. So this is just as good as renal agenesis. Most of these kidneys will rupture on their own without any need for intervention. But if there is a compression effect on the baby after birth, then in that case, there is need for subcutaneous puncture by the urologist for this mass. But otherwise, unilateral multi-cystic kidney disease is good as unilateral renal agenesis. That's the counseling we give women. But bilateral multi-cystic kidney disease is as good as bilateral renal agenesis. That's the unfortunate part. That if we have multi-cystic kidney disease bilaterally, then the baby cannot live. It's a lethal condition. This is not very clear, but this is one of our cases. We had a keyhole sign in the bladder from posterior urethral valves. Not very clear image. Again, a vein of Galen aneurysm. So when you are trying to do BPDH circumference and you see that there is what appears like fluid structure, put on color and you are going to see that there is a problem there with a vein of Galen aneurysm. These babies may have some neurological features in life, and they may be need to close this. This is abnormal formation of the vasculature of the brain. This is one of our cases here. We are here to follow up on the surgical intervention of this case. All right, I've already taken you through this. Corpus callosum agenesis, probably, I didn't show you an image of the corpus callosum in the protocol, but whenever we are at the sagittal plane, we try to look at the corpus callosum. If we don't see it, we put in the blood vessel to try and map out the anterior callosal artery, which you can see there is no good continuity here. So this is as a case of more probably between partial to complete agenesis of the corpus callosum with varied neurological outcome. Pulmonary sequestration. Sometimes you may see some echogenic structures within the liver, within the abdomen, where there is abnormal, what appears like pulmonary tissue within, outside the pulmonary cavity. Sequestration may be pulmonary or extrapulmonary. Normally, these masses will have a feeding vessel. The good thing about these masses is that the majority of them may self-resolve, but if they don't self-resolve, they may cause some arteriovenous malformations and challenge the baby after birth, and there may be need for excision. This is one of our cases we followed up. Fortunately for this one, this one self-resolved. The echogenic mass you see there. Just to show you again the choroid plexus cyst within the choroid plexus. Again, this was bilateral choroid plexus cyst there. Okay, I think, right. This is another image of the mid-fascial defect of a holoprosencephaly baby. You can see the abnormalities, sometimes they are varied. This is a clear proboscis. You can see there's no nose there, there's flat nose, so there's arrhythmia in this case. In this case, the proboscis is probably the place of the nostril. You can see there is a fluid structure there, which is big. At the place of the nostril, you don't see the upper lip clearly. And in this baby, he had cyclopia. There were no orbits, no, not cyclopia, but microphthalmia. It had very tiny eyes. That's holoprosencephaly. These images, I think you've already seen them. Sometimes you see increased knuckle fold, echogenic kidneys. This is another, this is more like semilobar holoprosencephaly, where there appear to be some division, but when you go to the front, you see that this is a univentricle, right? This is a lobar holoprosencephaly again. Very important to identify because it's totally different from, this is another case of more semilobar holoprosencephaly. I think that is it. This is, yes, more of the images showing the various terminal myelomeningocele. This is cyclopia. That's an orbit in a holoprosencephaly baby there. So this one had one orbit, cyclopia. Right, there we go. There we go. You can see there a very small cerebellum. Right, these images you see, this is a submembranous VSD measured in that image. So in a nutshell, this is what we have in terms of common fetal defects and how easy. This is a case of pleural effusion. You can see fluid in the thorax. This is multiple congenital defects, ascites, and also fluid around the liver there, ascites, and some mild hydronephrosis bilaterally. This is hydrops, hydrothorax, fluid in the chest, and abnormal hydronephrosis kidneys, which are already echogenic here. This was another baby with, this is a rare neck cyst we saw in that image. Right, I think, thank you so much for listening, and I would like to thank the FMU and the FMFZ team The images that we see presented here are images in our library. I think for my colleagues who presented, all the images that you showed us here, remember they are all, we have them, we'll probably have better ones in our library. So use the library which we have, because that's our work.